Sir, you can start your talk just after 10 seconds, sir.
Atahar bhai, you can start now.
Yes, welcome everybody. Good evening from Dhaka, and welcome our respectable international faculties, Dr. Rafique Ahmed sir, Chowdhury, Hafizul Hassan, and I can see Dr. Arun Maski. Welcome, Arun Maski.
Yeah, hi.
First of all, I should always welcome Dr. Toufiqur Farooq, our today's speaker. He is also ready. Professor M.G. Azam, Professor Mohsin Hussain, Dr. M. Shafiq, and our Dr. Abdul Al Jamil and Dr. Nazmul. Welcome everybody. And today there will be two speakers. First of all, our first speaker is Dr. Toufiqur Farooq, followed by Dr. Chowdhury Hafizul Hassan. He will show some ECGs. And for the beginning, I want to Dr. Toufiq. We have got the two speakers here. The first speaker, you will get nearly about 45 minutes to speak. 45 minutes, followed by the Dr. Chowdhury Hafizul Hassan. We will try to.
Atahar bhai, me and Rafique bhai together, actually.
Okay, no problem. Yes, Toufiqur Farooq will be followed by the Chowdhury Hafizul Hassan and Dr. Rafique Ahmed. And Dr. Farooq, you will get nearly 45 minutes for your lecture. So Dr. Farooq and I will, I want to request Dr. Abdul Wadud Chowdhury to introduce our favorite Dr. Toufiqur Farooq, very popular cardiologist, Dr. Toufiqur Farooq and Dr. Abdul Wadud Chowdhury.
Good evening, everybody, and assalamu alaikum. Today, we are going to have a talk from Dr. Toufiqur Rahman. His nickname is Farooq, actually. I was lucky in the sense that he has been my student when he was in third year. Again, he became my student when he was in MD Cardiology course at NICVD, our national institute. So he's a brilliant doctor, a brilliant student, and he's a prolific writer. He has written many articles published in national and international journals. Also, he has written some popular books on cardiology for the general population. Very few people can actually claim that credit. Dr. Farooq is like that. Today, I'm hoping that at present he is Professor of Cardiology and Head of the Department at Colonel Malek Medical College at Manikganj. I hope we'll be enjoying today his lecture on STE, and it will be a ECG-based lecture, so it will be mainly on the diagnostic front. So, Dr. Toufiqur Rahman Farooq, the stage is yours.
Thank you, sir. Thank you for your nice introduction. And thank you, Abdul Chowdhury sir, Atahar sir, for inviting me and give me opportunity for today's lecture. And also thanks Chowdhury Hassan sir and Rafique Ahmed sir for joining with us. So now let us start. So my today talks on ST elevated MI. As per instruction from Professor Atahar Ali sir, actually I have tried to make the lecture as simple as possible and to be understandable for undergraduate students as well as interns. So at first, this is the starting with a case scenario, a very simple case scenario. A 55-year-old hypertensive smoker, diabetic and dislipidemic gentleman presented with central chest.
Slide show, please.
Sure, thank you. Presented with central chest tightness with excessive sweating for the last 45 minutes, not relieved by taking sublingual nitrates. His tachycardic and his blood pressure raised, and his diabetes is uncontrolled. A1C is 8.2%. His ECG showed ST segment elevation in P5 to V1 to P5, and troponin level is also raised. What is the probable cause of his chest tightness? Review, can you give poll?
Yes, sir. Starting the poll.
Toufiq, we do not see any ECG.
So next ECG, sir. Next ECG, just starting with history scenario.
But you are asking the question without seeing the ECG. How can they answer?
Sir, there is a information that his ECG showed ST segment elevation in V2 onto V5, and troponin level is also raised.
So you want to do the poll on this case scenario, na? Not
Case
on-
scenario, yes, sir. Only on this case scenario.
Start the poll, sir.
Question
Yes.
is that case scenario on the top of his description, ECG showed ST second elevation V1 to V5. You are asking the diagnosis, ECG diagnosis, right? ST.
Yes, yes.
Sir, I'm giving 30 seconds to answer.
Yes, 30 seconds, enough, I think.
Okay, sir.
Excellent, 39 participants. That is the number C, Toufiq.
Yes, number C, this is the correct answers also. So most of the participants give the correct answers. So now proceed to next. This is an ECG. This is an ECG of a gentleman. He is diabetes and hypertensive. So what are the ECG findings here? There are 4 options here. And this can also be a go for poll.
Okay, sir, we have started the poll.
Please vote. If you're wrong, that's okay. You will be right when you're treating the patient. If you're wrong, it is better to be wrong now.
Yes, sir.
But vote, please vote. Nobody's seeing. Commit yourself.
Yes, participants are requested to answer. No problem, right or wrong.
Yeah.
As many as possible. 30 seconds review. Poll results. Number D.
How many voted?
27, nearly 40, more than 40 actually participated in the voting.
Getting better, getting better.
Sir, just if we can give them a bit more time, I guess. If it's 1 minute, it would be better. They can answer.
No. 30 seconds is okay.
Okay. Okay.
So all of the above. Actually, Toufiq,
So-
we want some discussion on this ECG.
Yeah, yes, sir. Yes, sir. Yes, sir. So around 61% gave the all of the above, and all of the above actually the right answer here. And there is we see from this is that there is a ST elevation and hyperacute T waves in V2 to V4. There is a Q wave and there is a ST elevation, and also there is a T wave, hyperacute T wave from V2 to V4. So A is correct. And ST elevation in 1 and AVL with reciprocal ST depression in lead
Lead 3.
lead 3. So there is a ST elevation in 1 and AVL, and there is reciprocal ST depression in lead 3. And also there is a QFs in V1 to V2. So all the answers are correct here. So all of the above is the correct answer of this question.
But Professor Toufiq,
Sir?
actually, can you clear what is hyperacute T, and is it really hyperacute T in V1 and V2, V1 to V4?
Actually, hyperacute T, when there is at least 10 millimeter height of the T wave, then it is called hyperacute T, or and as it is associated with this Q wave and there's ST elevation. So, and there is around 8 or 9 millimeter height of this T wave. So I think it can be hyperacute.
Another thing is that at the time of hyperacuity, there should not be any Q wave.
Chowdhury Hassan.
And it's a wide and tall T wave.
So the pattern of the T here is probably suggestive of hyperacute, but I would refrain from using hyperacute when there is other features such as ST segment elevation, and there is early indication of Q wave in the V1, V2. I probably would not use hyperacute, but it looks like hyperacute. Tall tented T wave with the 10 millimeter up is the definition, but I think it is okay to use the hyperacute here. And then looking at the history of 45 minutes, I would buy it as an hyperacute.
Yes.
Abid, how can you explain Q in V1, V2 in 45 minutes?
So that's why I don't like to use the Q, because how early you can get Q. You know, usually we say 4 to 6 hours, right? But if you look at this, the V3 and V4, there is no Q. And then is V1, V2. So it's very difficult that this is a definite, Q wave MI. So the dictum is that if there is a Q wave, that doesn't mean it is transmural and you don't need to do anything. So that Q wave means nothing on that. And if it is subendocardial, Q still can come. And this is one of the reasons in the business of STEMI, we don't talk about Q wave anymore. That this old EKG thing, QMI and non-QMI, because that may confuse you for intervention or not intervention. Because if it is a completed infarct.
Abis bhai, one question is that whether in V1, is it Q?
If it is just V1, you cannot. The only problem here is that V2 is V2 also. I don't see any upright. But what I'm trying to tell you that transmural, yeah.
Normally in V1 and V2 there may be QS pattern. If we consider that, then this T wave can be hyperacute.
Well, that's why I pointed out that V3, V4, when this is R wave present,
yes.
In this Q, is it pathological Q of MI or is it Q wave of physiologic? That sometimes we
physiological, if we consider this as a
and the other point is that if the leads are placed to proximity, then V1 you are always allowed. V2 is the questionable, and the V2 is placed close to, you can't tell. So I would not entertain this Q business in the presence of STEMI for the management purposes.
One more question to Professor Abdul Wadud Chowdhury.
Yes, Atahar bhai.
Yes, one more question to Chowdhury, followed by Chowdhury Hassan and Tawfiq. I can see some discrepancy of the ST segment elevation pattern. That is ST elevation in V1, V2, V3, and V4, but almost it is normal in V5 and V6, but still, again, ST elevation in 1 and AVL. Is there any explanation or I am wrong?
Yeah, that's very correct. I was looking at the same thing. Because if you consider arterial territory, there should have been ST elevation also in V5, V6.
Yeah, but I would not, but it is anterolateral. We'll have to call
it's anterolateral, yeah.
Only possibility that if we consider the anatomy, if there is collateral from the right side to the apical region, then V5, V6 might remain normal, even occlusion in the proximal segment of the LAD.
Now there should be near normal in the apical region V3, V4.
V3, V4 is septal. Apical is V5, V6. And lateral wall is 1 AVL, V5, V6 we consider near the septum, lateral wall. And if it is occluded in proximally, if a diagonal, large diagonal is occluded, that will give 1 and AVL ST elevation. And in the apical territory of the lateral wall, if it covers by the RCA, then it may remain normal as in this ECG.
Yeah, can I make a comment?
Sir.
Yes, sir.
Yeah. So the question that Atahar asked for the young doctors, if you look at lead 1 and AVL, actually it is a little high lateral.
Yes.
V5, V6 is a low lateral. And that can explain the discrepancy. I mean, discrepancy in the ST segment elevation that you can see in 1 AVL, not in V5, V6.
Right, sir.
Thank you.
Sir, one more question to Chowdhury Hafiz.
Yeah.
Hello? Sir,
Yeah.
actually, from this description and this ECG, is it right to take the patient in the cath lab?
Well, it's called the
But it's
question
the
is,
pain for 45 minutes. That's the
Yes.
most important thing.
so the question is, this is like what we are dealing with. The working diagnosis is acute anterolateral ST segment elevation MI. And then first thing we say, ideally the patient should have the primary PCI if possible. Is the patient electrically stable, hemodynamically stable, any complications, any cardiogenic shock? All these needs to be into consideration. But in the absence of that, you don't need anything else but to think about primary PCI. If not possible, then pharmacoinvasive is the way to go.
Professor Farooq.
Sir, next.
By the way, I wanted to tell you one thing, that ECG explains, but it does not always explain. And time will also play out, you know.
So can I go to next?
Sure, Professor Farooq.
Sir. This is another ECG. The patient presented with chest tightness and sweating. And this is the straightforward was the ECG diagnosis of this patient. And these are 4 options here. And review poll.
What is the 4th one? I don't see the 4th.
So 4th one is extensive anterior STMI.
Let's see whether more than 50 answers.
Participant, you please answer, right or wrong, no please.
Huge.
Most of the
So
cases.
we have passed more than 50 participants.
Yes, excellent participant, more than 60, I think. No problem, but high lateral.
This is the correct answer is most of the cases around 79% give the correct answer. Extensive anterior STMI is the answer. So there is a ST elevation in V1 to V6 and 1 and AVL. And that suggests the extensive anterior ST elevated MI.
Professor Farooq.
Sir.
You can clear for our participant that is this term, high lateral, anteroseptal and extensive anterior for our junior participant.
Yes, so this is the actually ECG localization of the myocardial infarction, especially ST elevated MI. In case if there is a ST elevation in V1 to V2, that is V1 to V2, this is called septal MI. And if ST elevation is V1 to V4, that is called anteroseptal MI. If ST elevation is V3 and V4, that called antero MI. And if there is ST elevation from V1 to V6, that is called 1 and AVL, that is called anterolateral MI. and ST elevation V1 to V6 and 1 and AVL, that is called extensive anterior MI. And if there is only V1 to V6 ST elevation, that may call anterolateral MI.
Thank you very much. Is there any specific term for this kind of the ST elevation, Chowdhury Hassan?
So
Actually,
I differ a little bit. V2 and V3 is called strict anterior MI. Strict anterior means septal. And V1 to V6, either anterior or anterolateral. These are interchangeable terms.
Now, what is your strict anterior?
Strict anterior is V1, V2, V3. That is septal.
These two lead, V2 and V3, strict anterior.
Strict anterior.
So can you go back one slide? Can you go back one?
Previous slide, Farooq.
Yes,
Previous
sir.
slide.
Yes, sir. This is the first one.
And the second, did you have a follow-up on this patient?
Yes, sir.
Follow-up EKG?
This is the same patient after 30 minutes of the first patient actually. And there is a more ST elevation in the V1 to V4 actually, and it also extends to V5 and V6. And also in the 1 and AVL.
That's what I was going to say, that EKG does not, it tells a lot, it does not tell you the whole thing. Sometimes in time delay can assure you that it was extensive anterior and the lateral, V5,
Yes,
V6. So whenever you are not seeing it, that doesn't mean that it's not going to come. It sometimes takes, there is a lag time. I don't know why, but that happens. But in the board purposes, I use it more often than clinical purposes. In the board, they want to know whether there is an injury pattern of MI, and then if there is an EKG with the leads, then V2, V4 actually also included in the septal, and then V5, V6 anterior, and then when there is a 1 AVL, then it's a lateral extension. So, yeah. But this pattern is also important, and I'm very pleased that everybody is recognizing the ST elevation pattern is ST elevation MI pattern.
Abdul, can I make one comment? Here there is R wave gradually decreased in the inferior leads as well.
Yeah.
Probably this is wraparound LED.
Possible, yeah.
Yes. So,
will you move?
Chowdhury Hassan, actually, what do you mean by the injury pattern ECG? Injury pattern, what is the ECG changes here?
So the injury pattern of MI, injury pattern of pericarditis. When there is ST elevation, you need to know that this is like a injury pattern ST elevation. Is it concave upwards pericarditis type, or is it MI type? Clearly, in this case, it is ST elevation MI pattern.
Thank you very much. Professor
Sir,
Farooq?
there is a question in the question answer box. ECG sensitivity and specificity by Dr. Mohammad Mir Sufyan.
Sensitivity and specificity. Achha, we'll discuss the answer afterwards. Achha, Professor Farooq, please.
Sir, this is another case. This is the gentleman present with chest tightness and shortness of breath. And this is the ECG, his ECG. And what are the ECG findings here? There are also 4 options here. And review, you can go for poll.
Yes, sir, I've started.
Yes.
while there's loading, to answer the question, the specificity of ECG for a STEMI elevation, STEMI in the right clinical context is over 95%, but the sensitivity can be low. It's about maybe 66 to 70%.
Thank you for answering and participating in the poll. Around 76% answer with all of the above, and this is the correct answer. And all the features are present here. ST elevation in V1 to V6 plus 1 and AVL. So there is ST elevation 1, this ST elevation AVL, ST elevation V1 to V5 and V6 slightly, and QFs in the V1 to V2. Reduced RF height in V3 to V4. RF height, there is a reduced of the RF height in V3 to V4. And there is a PVC here and the end of the ECG actually. This is PVC with R on T phenomenon actually. And these are the all answers here. So this is the correct answer.
As a Professor Farooq,
Sir.
Actually you have highlighted this PVC, that is R on T. From this ECG single PVC with such malignant character, what should we do? Is there any precaution we should take for this kind of the ECG from the single?
Yes, sir.
PVC?
As there is a PVC with R on T phenomena, and this is extensive enteroma, so there is a large area of myocardium is jeopardized. So this patient may go into LV dysfunction, cardiogenic shock, and as well as patient may have malignant arrhythmia like VT or VF. So we have to cautious about this patient may have malignant arrhythmia.
The best, I don't know, Rafique bhai is here. The best antiarrhythmic is the reperfusion.
True, true.
So I think beta blocker or amiodarone can be given here.
I don't think that I would give amiodarone to suppress.
This is the question. This is the question we should discuss. Rubik, sir?
Yeah, so I have a comment. I mean, as Hafiz pointed out, is the ischemia is the culprit. It's not the PVC, is not the culprit. So we need to treat the ischemia. And in the setting of acute ischemia, if we develop any arrhythmia, once we fix that, there is no need for antiarrhythmic medication at this point. I mean, we preempt with it. It makes us happy, but I don't think it serves any purpose for the patient himself or herself. So I will refrain from using amiodarone in this kind of patient.
Wadud Chowdhury?
Sir, may I add one point, sir? Atahar Ali, sir?
Yes, yes, sure, MG Azam.
Yes.
In that particular situation, we must go for cath lab or primary PCI strategy first. If possible. If not possible, at least we should go for lightings. Then we will go for next strategy. Second thing, we should look for whether the patient have features of heart failure or very high risk of heart failure, like if blood pressure less than 120 or heart rate more than 110 or heart rate less than 60. If no features, then we no evidence of heart failure, then we should introduce beta blocker as soon as possible to reduce the further complications of which related to MI related complications. So this is my recommendation, sir.
Thank you very much. Is there Professor Chowdhury, Abdul Wadud Chowdhury?
Yes, please.
Yes, actually, this is very pertinent and interesting question to know from our participant is that, is the STT changes in lead 3, AVF and 2, is it reciprocal changes or sometimes we see the reciprocal changes and sometimes we don't see? Is there any explanation from your side?
Actually, we do not have that any explanation, but the point is, if we have the reciprocal changes, it definitely goes in favor of acute ST elevated MI, because you can have a persistent ST elevation in an old MI case because of the presence of ventricular aneurysm. But if you have the reciprocal change in the clinical context, you can rest assured it's a case of acute MI. One thing that we should be remembering that ECG has high sensitivity for diagnosing MI in a particular clinical context. That's what Hafiz Bhai was saying. But ECG, change in the ECG do not actually determine how much of the myocardium is involved, because you will find out sometimes there is Q wave or ST elevation only from V1 to V3, but there is severe LV dysfunction. Again, you may find sometimes ST elevation from V1 to V6, 1 AVL. You are thinking this is an extensive anterior MI. Patient will have severe LV dysfunction. You may not get that. We should remember that. You can diagnose MI, but you cannot be sure always how much of the myocardium is jeopardized at that particular moment.
Regarding
যদি সুন্দরবনে যে যদি বাঘের ছায়া দেখেন বুঝবেন যে বাঘ আছে, আর যদি ছায়া না থাকে তাহলে এই না যে বাঘ নাই, কিন্তু ছায়া দেখলে বুঝবেন যে বাঘ আছে যদি জায়গাটা সুন্দরবন হয়।
Regarding reciprocal change, some authority considers that in those area also little bit jeopardized, maybe that there was some collateral from the feeding vessel that was blocked and did the MI. Say from LAD there was some territory supply through the collaterals to the inferior surface, as because of there is some non-occlusive, say significant but not totally occluded lesion in the RCA. In that case, there might be reciprocal changes in the inferior area also.
But Jamil bhai, generally speaking, we should consider reciprocal changes as whatever is happening on the other side.
Yes, yes.
If the proportionate ST changes are more than expected, meaning that if the inferior is classic example, if the inferior ST elevation is 3 millimeter, but the precordial ST depression is 6 millimeter, then it is more than reciprocal. That means there is something additional going on, maybe posterior. Yeah. Okay.
Can I ask a question? Can we differentiate the reciprocal change from the previous T inversion due to any cause?
Reciprocal change actually indicate the ST segment, not to the T wave. We should remember that.
Or previous ST depression due to any
ST depression. Previous ST depression, classically the reciprocal changes has some sort of downsloping or a saddle change or horizontal shape. It's not not classical downsloping. It's either horizontal or a saddle shape. You should remember that. But T-wave change do not count as a reciprocal change.
So, Professor Farooq, our Dr. Rehan from Mymensingh Medical College commented that is a reciprocal change. This term should be ischemia at distant. Do you have any comment about this? That is reciprocal changes versus ischemia at distant.
Yes. As Dr. Nazmul said that if there is a previous ST depression or ST with T changes without any ST elevation in anywhere, in that cases actually that denotes that there is a ischemia in that wall. But if there is a ST elevation and there is a just reciprocal that change, that's if there is a 2-3 ST elevation 2-3 AVF and there is reciprocal change is 1 on AVL, and that suggests this is a reciprocal change. And in that cases, it just reflects the ischemia. That's actually the reciprocal change. But if there is a without any ST elevation, but there is a ST depression, and actually in that cases that indicates ischemia.
Yeah, reciprocal change is always related to ST elevation in one side and depression in other side.
Yes, sir.
There is another query that as we are getting in case of anterior or anteroseptal MI, we are getting reciprocal changes in 2-3 and ABF. But in case of inferior MI, we are getting in reciprocal changes in usually V1, V2 or V3. Is it universal rule, or we can get reciprocal changes in other lead also?
Nazmul missed a question actually.
Sir, in case of anteroseptal MI, we are getting reciprocal changes in inferior leads. That means 2-3 AVF. And in case of inferior ST elevated MI, that means 2-3 ST elevation in 2-3 AVF, we are getting reciprocal changes in V1, V2. Usually V1, V2 or sometimes V3. So
no, actually the inferior MI reciprocal change is actually in 1 AVL.
Oh, sorry.
Remember that Remember
Yes,
that
yes,
if
1
the
ABL.
RC is involved, reciprocal change is there.
Yes, yes,
If the
yes.
L6 is the supplier or dominant vessel, reciprocal change is less.
Yes, sir.
And if there is reciprocal so-called ST depression in V1, V2, V3, you should consider that it's more likely to be posterior MI. You should do a posterior lead
Yes,
then.
yes, yes.
The classical change associated with inferior MI, reciprocal change is 1 AVL.
Professor Farooq.
Sir, we'll go next.
I will request you to just show one more ECG before finishing, as because we have got the 2 more speakers. Just one
Yeah,
more. ECG.
okay, sir. Okay, sir. Just I will show one more ECG. This is the another ECG that a patient present with chest tightness and shortness of breath, and he has the following ECG. And so, what are the ECG changes here? Any comments from any fellows or any students?
Yes, I can request Professor Zaman.
Sir,
do you have any comment?
In this ECG, there is sky level elevation of the ST segments involving the 1 AVL V1 to V6 with reciprocal ST depression in the inferior lobes.
What is the term he used for this ST elevation?
ST elevation, the magnitude of the ST elevation is very much high. The term used the Pahar Samo elevation at the terminology.
Yeah, it is called tombstone pattern.
Tombstone pattern, actually, yes.
Exactly.
It looked like that.
Term. Actually, I didn't get
tombstone pattern, right? Dr. Rehan.
Yes, tombstone pattern.
Tombstone pattern. Thank you, Dr. Rehan.
Sir, it's indicate the extensive.
Thanks, Dr. Vasudev Ganguly.
Yes, extensive entry MI.
Along with sinus tachycardia.
Yes. With tombstoning morphology. And this also indicates there is extensive myocardial damage.
So
I will stop here, sir. Or I'll go for another ECG.
Sir, is there Rafique, sir?
Yes.
Sir, what is the rhythm, sir?
I don't see a clear-cut P-wave.
The problem with this ECG is that there is so much baseline issue that if this patient at first, it can be sinus tachycardia. I think it's most likely sinus tachycardia in the setting of an acute MI. If you look at lead V1, end of the T wave, there is something. And sometimes if there is a first degree block, so you cannot make any really concrete comment on the rhythm itself. Definitely supraventricular, no question about it. Most likely sinus tach.
The V5, V6, very clearly pure can be discerned.
Yes.
Sir, does ST segment elevation, degree of the ST elevation, denotes always the degree of damage of the myocardium? Is it always true, sir?
So, Atahar bhai, I just sent you a table about contiguous lead definition and also reciprocal lead changes. But in any case, this one, I would say tombstone, or if you look at V5, V6, almost looks like shark fin. These EKGs are very bad because they go into, and Rafique bhai is here, these patients are very easily go into V fever arrest, and is very, very problematic. And these are usually, they don't do well. There sometimes they may have significant comorbidities and cardiogenic shock, complications, all these to be very aware of. And this patient with the shortness of breath and borderline blood pressure or hypotension, before we even dream of taking to the cath lab, we should preemptively intubate. I usually take care of this before going to the cath lab. It's very, very important. And the magnitude terrifies you that this patient may go into VP very soon.
Professor Farooq,
Sir,
do you have any
so,
more comment?
sir, I should stop here.
Do you have any more comment about this ECG? This is very much dangerous.
No, sir. As Chowdhury Hasan sir said, actually this ECG denotes that there is a extensive myocardial infarction, and this patient go into left ventricular LV dysfunction, cardiogenic shock, and acute left ventricular failure. So this patient should go into the cath lab, and reperfusion should be done as early as possible.
Can you give some idea how did you manage this patient? Do you have some information?
Standard anti-ischemic therapy should be given, and according to the if primary PCI is available, this patient should be sent to the cath lab. And primary PCI is not available, then streptokinase or other thrombolytic should be given.
I have a question to Dr. Hafiz Bhai, that he was telling about the intubation before going into the cath lab. Is there any role of prophylactic intubation before the development of any acute left ventricular failure?
So, as Rafique Bhai pointed out, look at this. This is tachycardia and then extensive. So, LV is not going to be normal for sure. And if this patient has shortness of breath, frothy sputum, then you know that this patient is not going to do well. So few things we look at, that you can give preemptively diuretics, and then make sure that you have support plan. Tell the ER that we are moving, but we may need you for intubation.
Exactly.
Give morphine, give the diuretics, and get a chest X-ray, and if you can do the echocardiogram, that's good. But whether to intubate or not, it depends on already hypoxemic and the hypotensive. Then you know this is going to be a catastrophe in the cath lab. So I usually go for preemptive intubation. Particularly the excuse is if the pulse ox is really low, like below 90.
Sir, two short questions from our participant. Rafique sir.
Yeah.
Actually, one of our MBBS student has want to know. You called it supraventricular. He wants to know why it is supraventricular this time.
Well, the question is, if you look at the chest lead, let's forget about V1 and V2. It looks like a wide QRS, but that's mainly ST segment. If you look at lead 2 and 3 and lead V1, the QRS is narrow. So that whatever is driving this rhythm is not from the ventricle.
Yeah.
And it's most likely sinus tachycardia.
Yeah, and the V6 is clearly P wave, looks like.
Well, that part is a little confusing, Hafiz, because that can be part of the QRS complex. That's the problem part, because the ST segment is so distorted that if that is the P wave, that will be probably very short PR. But the whole point is that acute management of this patient is important, that the quick recognition of that, as Hafiz mentioned, quick recognition and taking action, in this case, preemptive action, whether to intubate the person, do it quickly, take it to the cath lab as quickly as possible. Otherwise, you are going to lose this patient, right, Hafiz?
Yeah. And then lead 2 assures me that particularly that this is the early depolarization. In the EP world, what you call that, the early depolarization phase is very narrow, Rafique Bhai. So probably it is supraventricular mechanism rather than ventricular mechanism.
Exactly. Thank you. This is a good lecture series.
So thank you, Dr. Durjay Das, for your questioning. We always appreciate the questioning to the chat box. So thank you, Dr. Durjay Das. Another of our participants wants to know from previous Dr. Chowdhury's lecture. He used the term sharp in fin. He wants to know, does this ST segment elevation fits with your term, that is sharp in fin?
So the V5, V6 looks like, but V1, V2 is more like a tombstone. And the tombstone means that it looks like tombstone. Tombstone means like patient is on the way to Tombstone. But V5, V6 looks like shark fin.
So thank you very much, sir. We want to thank Professor Toufiqur Rahman Farooq for your excellent and beautiful presentation and the beautiful ECG collection for our everybody and particularly for our younger students. Thank you, Professor Toufiqur. Sir, Professor Farooq has got many collections. He has got many collections and we want.
Before your talk, can I show one ECG?
Yeah, of course.
Okay.
Well, by the way, Rafique, I'm going to show today's EKG and I'm going to throw some poll and then you can comment.
Definitely. So I'm going to, because interesting, because I always find ECG is pertinent to this lecture today. This is one ECG. You see, in the previous ECG, there was ST elevation in lead 1 and AVL. Here, I have ST elevation in V5, V6, and depression in 1 and AVL. So I put some questions up there. This is the only ECG that I will show. And what do you say? And it's, of course, very close to the immediate preceding ECGs that were shown. And I cannot comment on this because this is Hafiz and Wadud's territory.
So should I start the poll?
Yes.
The patient is a mature person, so he will be extensive coronary artery disease. That's the clue I will be giving to the audience.
So this kind of EKG, I don't know, Wadud, what's your comment? But you can explain by one artery, say right.
Is the dominant artery supplying an occluded LED?
Yes. That is exactly right.
Posterior branch is very big.
But,
okay,
and
follow your comments. Okay.
Beautiful.
So this is excellent, right? Answer.
Yes, everybody's that's excellent. 65% correctly answered.
Okay. I mean, I put this sinus rhythm versus sinus bradycardia because the heart rate is 50. That's semantic, but combined, close to 90% answered it correctly.
Both 3 and 4 actually correct.
Okay. Yeah. Now, I just put a slide here just for a visualization of where this ECG is. Leads V1 and V2. V3 will be a little down on a horizontal plane here. And this is where 1 and AVL is. So whatever changes, and then I have 2, 3 AVF. So there is definitely acute ischemia inferior territory, and then adjacent territory and an anterior. Oh, in this area, right? And yes, this area, 1 and AVL is a mirror image, and that brings us to the ECG here that there is ST depression in this list. Now the question would be which vessel? And Hafiz and Wadud, what do you think?
So first of all, Rafique bhai, acute simultaneous in two territories is rare, but rarely it can happen. But we always try to make it with one territory. And but if we cannot explain, then we invoke that, oh, the other vessel was occluded, and it gives this scenario.
I think Wadud gave the answer. And I have the picture. This is the right coronary.
Yes.
Totally occluded, and once it's opened up, it's a super dominant, really dominant right coronary, right?
Big posterior branch, yeah.
And then Wadud, I think, knew this patient. Look at this. LAD has the tight ostial stenosis. So actually, this is this was fantastic that Wadud just pointed out on the right one. And I think that is also circumference stenosis, what do you think? It's difficult to see in this vessel, but there is tight osteal stenosis of the LED. So that's why this is it. I'm going to go back to this ECG
so,
again.
Rafique, but showing this is very important, because what happens sometimes, we have patients where we need to choose the guide. And I have said this before, sometimes it becomes, and you don't follow cricket, Rafique bhai. That is so unfortunate that you don't follow cricket. but I think the rest of the cardiologists, they follow. So when there is a T20 game and I have like 5 minutes, then I need to choose the guide. So if I know that the infraclavicular artery is right, I go up with the guide, get this artery open, get the dot to balloon, and then look at the other things as needed. So it is very important that way to know which one is the culprit artery now, you know.
Sir, we have
ask any question, please, sir? Sir, can it be because of the LED occlusion, which is wraparound, that is type 4 LED?
Possible, yes. Yeah.
Sir,
in those cases, V1, V2, there should be ST elevation as well.
sir, now question to Professor Wadud. Wadud.
Yes. The thing is, sometimes we can get because the ST depression in V1, V2, that actually suggests the posterior wall is also greatly involved. That's why I was saying the posterior lateral branch will be very big, and it was so.
All right, good. Thank you very much. That's all I have today. And Hafiz, it's yours.
Sir, excellent ECG.
Thank you.
Dominant LCX occlusion of the বলা যেতে পারে, sir.
You cannot say that because the ST elevation in leg 2 is much higher than those in leg 3.
However,
that should be hidden.
That is against the point, but that is not always the rule. So.
Yeah.
There is a point.
Yeah. But let me inject that, Wadud. That criteria of Marriott, when tested, it was neither that sensitive, neither that specific. So I just, for academic discussion, we say it, but it's not really practical. You need to go by your hunch at that point. But still, if you think that you need to go with the guide because of time constraint, my rule book is that define the coronary anatomy, both sides clearly, before you make up which one is the culprit. Some particularly non-STEMI elevation MI, this can be a big problem. And sometimes we see that in the acute STEMI as well. So I don't know whether you can see this. 65-year-old motor vehicle accident 2 weeks ago, came with abdominal pain and shortness of breath. And can you see the probability that you will entertain? So C means sinus rhythm, pulses alternance, and low voltage. And D means sinus arrhythmia and low voltage.
You want the poll? Review poll?
I have started the poll, sir.
Hafiz bhai, did you mean pulses alternance to mean electrical alternance?
Yes.
Okay. Thank you.
Thank you, Zaman, for clarification. Thank you.
Just well manifested in V1.
Not bad, Rafique bhai.
Yes, good participation. Number C, that is sinus rhythm, pulses, electrical alternance plus low voltage.
So, to be honest, it is purely a QRS alternance, right? You see the QRS amplitude is varying. in each beat to beat variation. If it is beat to beat variation, then it is not sinus arrhythmia.
Yeah.
Sinus arrhythmia is with the breathing.
Yeah, this is a wonderful ECG, because if you look at it suddenly, you don't see it. But of course, here the clinical scenario comes into play. That somebody who had a motor vehicle accident, what could have happened? And then you look very carefully. If you look at the rhythm strip in the bottom, that subtle change in voltage, you can see it, very subtle. Of course, in V2, you can see the difference much better. So there is electrical alternance. Of course, Hafiz has the echo also.
And look at the LV. It is swimming in the pond. And then see that the tamponade physiology across the tricuspid valve, huge variation. See that? So, and 1100 cc was drained.
Always blood?
Large.
Why was there no tachycardia in this patient?
That's very interesting. I was expecting a little bit more tachycardia.
Dr. Arun Maski, excellent point. And this is such an important point that I will have to report back to you. I asked for thyroid because I thought that this will be hemorrhagic, but it is actually not hemorrhagic. And the TSH is pending. So this is interesting.
I want to comment Arun Maski's question. Arun Maski. Actually, pericardial effusion, when it becomes the tamponade, there is a term called the Beck's triad. That is the low blood pressure, high pulse rate, and the low voltage. So unless the patient develops the features of the tamponade, pericardial effusion, severe pericardial effusion does not always produce the tamponade features. I think this may be that is the patient has got the pericardial effusion, severe pericardial effusion, but does not fulfill the criteria for the tamponade. I think that is hemodynamically stable. I think this patient.
So a couple of things. Okay, go ahead, Rafique bhai.
Hafiz. So I think it's interesting because motor vehicle accident, somebody comes to the hospital and you think of hemorrhagic effusion because there was bleeding, which did not happen. So is it possible this patient had a chronic pericardial effusion?
Yes.
And it was something different. That will answer Arun Maski's question that somebody who is chronic pericardial effusion and blood pressure is fine, hemodynamically stable, may not have the tachycardia.
Yes, sir.
So this is a wonderful case. If you could follow up on the thyroid function or what they found about this case, that will be very interesting.
Yeah.
Do you have the EKG after tapping?
Sir, I have a point for your comment, sir. Actually, this is expected to be acute as because the patient does not have the STD changes. In case of the chronic pericardial effusion, hemorrhagic, long-standing, there should be simultaneous STD changes. This patient does not have any changes, sir. Only the electrical changes, voltage changes.
Yeah, but the ST changes is unreliable for defining acuity or chronicity. And then the Beck's triad, like hypotension, jugular venous distension, silent chest, these were only one was there. And Beck's triad important to point out. But in this case, the lack of tachycardia was little surprising. So talking about tachycardia, this patient was not tachycardic, but complained of palpitation. So, Rafique bhai.
হাফিজ ভাই, পেশেন্টের ক্লিনিক্যাল সিনারিও এবং ইকোতে যেটা দেখা যাচ্ছে তার হার্ট রেট অনেক বেশি, কিন্তু আপনার ইসি এর সাথে এটা কোরিলেট করছে না। আজমের গলা না?
জি।
মানে তুমি কি বলতেছো, প্যালপিটেশন নিয়ে আসছে? কিন্তু হার্ট রেট যেটা দেখালেন ইকোতে যে মুভমেন্ট দেখাচ্ছে যে দা হার্ট swim in the pond so swiftly. It is যেটা ভিডিওটা দেখালেন, it seems to be at least 150 rate এরকম মনে হচ্ছে। তো এখন এটা এই সাথে কোরিলেট করছে না আর কি। তো এখন how you explain it?
না, তুমি এখানে দেখো যে এখানে হার্ট রেট কিন্তু খুব ট্যাকিকার্ডিক না, দেখছো? About 90-100, not like 130.
Exactly. That's surprising.
Right.
By the way, lately I'm doing this, what they call this, what needle that we use this for the apical approach, not the smart needle, micropuncture needle, and then using that, it's much better than using the big needle. With the micropuncture needle, the very small, in case you are going to RV, it's okay. Even if you go to the apical approach, because Mayo proposes the apical approach more than subxiphoid. But anyway, micropuncture needle is good. So Rafique bhai, this 39-year-old with this EKG.
Yeah. Do you have any questions? Did you put a poll there or no?
No, I just wanted to know anyone to comment what to do next.
So do you want? So do you want me to comment or anybody else? So the ECG, the question was patient had palpitation, but I'm sure when the ECG was done, he was not having palpitation.
Yeah.
So yes, so Dr. Rahman actually answered something very nice.
Yeah.
The ECG looks very good, but if you look at lead 2, you can see the there is QRS coming off the P wave. And same is true in lead V5 and V6. V6 P wave is difficult to see, but lead 2 is very clear. And so definitely this patient has pre-excitation. And so WPW syndrome probably, so of course the treatment will be cardiac electrophysiology evaluation, probably EP study and ablation if need be.
Sir, any comment about the voltage, sir?
Well, if you look at limb leads, it's not low voltage, because limb lead low voltage is 5 millimeter. Chest lead, there is low voltage. We don't know the body weight of this patient. This is the United States of America. I mean, 39-year-old can be like 300 pounds. So that's something that we have to watch out. That the rhythm, Dr. Shudisha asked, what is the rhythm? Rhythm is sinus, because if you look at lead 2, 3, 2, the P is upright, lead 1, P is upright, lead 1, AVL is upright. So this is a sinus rhythm with pre-excitation. Hafiz, any comment?
Probably he has asked,
you are mute.
Because there is some irregularities in the rhythm. That is why.
Hafiz, unmute yourself.
Let me tell you why I need to know about WPW, because the EP guys, they come for ablation, and I look at this and they said it's a quick ablation, but I want to know, is it left-sided or right-sided? And that is my main question. And Wadud, as an interventionist, we need to know, because we share the lab with them, and they usually take long time for the left-sided. Rafique bhai.
No, we don't share a lab with you. We have our dedicated lab. We have given up on you long time ago. I said no. So the problem with the location is when there is subtle pre-excitation, you cannot see the location as much. But lead 2 is upright. And the lead 1 AVF is almost flat. So that's why it's tough. With this level of pre-excitation, you can't tell much about the location. Just WPW syndrome, I will take the lab from anything between 1 to 5 hours.
Because there is a one, you can see there is a small R in the B1, so it is very difficult to say it is left or right side, or it is not true septum.
Yes.
So Dr. Sudhir wants
And
to
you will
know.
recommend to do a routine echo beforehand, right, Rafique bhai? In case there is a structural.
Definitely, any SVT patient, we should get echo, more so for WPW, to look at, make sure there is no Epstein, there is no significant valvular abnormality, all those things.
Sir, does it fit
According to
the criteria for sinus arrhythmia, sir?
Algorithm, it comes posterior-septal tricuspid annulus.
It is very difficult to say why, because there is small r in the B1, so it is
Just
very. It is not in the
from the
septum.
surface ECG, you can suspect only.
You can suspect.
Yes.
Chowdhury, have his previous
But
ECG,
we
please?
can choose the catheter and position of the catheter.
Sir, our student doctor Sudhir wants to know about the irregularity. Does it fit the criteria for the sinus arrhythmia, sir?
Yes.
Yeah, and this is a relatively young person, and you can see the rate gets is a faster, slower, and then faster, 2 cycles in one ECG. That corresponds to a respiratory rate of 12. So it's probably sinus arrhythmia.
Yeah.
Thank you, sir.
So this is a philosophical question. In the presence of left bundle, will you call it this EKG? Will you call it sinus rhythm left bundle, or you will still call it sinus rhythm left bundle and hyperkalemia? Sorry, there is a typo. So the poll is A or B.
The question at the upper left part of the
Left
ECG, na? Dear participant, only 2 options, A and B.
Patient is a 69-year-old end-stage renal disease on dialysis.
Equally divided.
B.
The P wave is too prominent.
So hopefully more than 60 will answer. No poll?
Yeah.
Ooh.
57.
A and B almost equal. Very tight
So
competition.
actually, this is any comment, Rafique bhai?
I mean, the first choice was sinus rhythm with left bundle. Second choice was sinus rhythm left bundle hyperkalemia. I will take both as correct answer.
Yeah.
The question is, if you look at the T wave, it is not only the height of it, but the width of it. It's a sharp, narrow T wave. And that I will be more inclined to call it sinus rhythm left bundle with hyperkalemia, even if Hafiz did not give me the clinical scenario. And this is not a very uncommon finding that the day before dialysis, lot of the renal failure patients become hyperkalemic, low range. And so Hafiz, what is the potassium? Did you know?
Yes, 6.1.
Yeah, so that explains it. Any comment from anybody else?
Wadud Chowdhury has got some comment. Master of T, Wadud Chowdhury.
Yes.
But what I was saying, if the P wave is more flat, I would have paid more attention to hyperkalemia. But as Sari said, the diagnosis should be encompassing all the important points: sinus rhythm, LBBB, hyperkalemia.
So I'm trying to show that this is EKG basics and beyond. So look at the EKG carefully, that you may see something basics. There's the argument that when there is left bundle, hands off, but you can still go beyond.
Yeah.
I mean, look at this EKG. T's are looking at you. So, and particularly if the clinical context is there, then always look for it. Now, this is a very, very important EKG in COVID time. This is a very, very important EKG.
Slide show, please.
Yeah, I'm going to show that. Yeah. Yeah. You can see now. 70-year-old male in ICU on vent, and the STEMI was activated.
They should check the ABG.
This causes a lot of anxiety in the hospital and challenges the utilization of the resources. So I think the responses are getting better.
And I'm happy that a lot of people are answering, and that's the way to go. Please answer as many of you as possible. It helps us evaluate ourselves also, that what we are doing. Are we doing any good job in teaching you? And also evaluate your group response. So please answer.
Okay, thank you. So Rafique bhai, interesting. আপনি আমাকে জিজ্ঞাসা করছিলেন যে ওই tamponade পেশেন্টের EKG পোস্ট বুঝছেন?
Yeah.
কিন্তু আমার এটা আপলোড করতে পারি নাই. There is, if you believe me, there is no QRS alternates anymore. I'm looking at this EKG now, and also the voltage is little better, but it's still low voltage. And we just received the TSH. TSH is high, T3, T4 is low.
So that's interesting.
Yeah, the motor vehicle accident was a red area.
Yeah.
And the patient presented with constipation also, abdominal pain with constipation.
Good.
Interesting. So this is interesting. So can you show the poll, because I wanted Wadud or Rafique bhai, if you can make comment, because STEMI with AFib and STEMI. So how you handle those?
Wadud.
Sir, we can take some comment from other panelists, sir.
Yes,
please.
Yes. Khalid
Anyone,
Zaman,
please.
MG Azam.
Oh, Azam.
Khalid Zaman.
Sir.
Hafiz bhai.
মানে এটা তো STEMI মানে ইন হাউসে কল করলে ক্যাথল্যাবে নেব কি নেব না এই কোশ্চেন এসে যায়। এখন মনে করো যে এই ইকেজি রিকগনাইজ করা তো খুব ইম্পর্টেন্ট, তাই না? এবং এর কিছুক্ষণ পরে রোগী পিএ অ্যারেস্ট হয়েছিল, বুঝছো?
Do you have any comment?
I think the changes, majority of the changes are compatible with hyperkalemia. Even in hyperkalemia, there may be some sorts of ST ligation and pseudo-infarction involving the inferior anteroseptal lobes. And there is no POM. Probably this change is due to hyperkalemia alone. Can we explain this only with hyperkalemia? If with broadening of the complexes and the pseudo-infarction pattern.
And what about the rhythm, AFib or sinus?
I cannot see the POM anywhere. So that can be explained by only hyperkalemic change, where atrium may become paralyzed.
And when you have hyperkalemia, you can actually be sure of the significance of the ST elevation. You have to, that's why I was saying that you should look at the ABG and look at the electrolyte.
Some irregularities is there.
All these changes can be explained only with hyperkalemia, rather than all the things.
And the QRS complex is a little bit bizarre. It doesn't look like typical ST elevation.
That's very important, Ramil bhai, what you just said.
Yes, yes.
Recognizing the pattern.
Then MI.
So we need to tell our ICU colleague that don't worry about STEMI. It is a metabolic acidosis hypoxic hyperkalemic blend. Is there any associated PE? possible, but is all non-MI issues.
Yeah, I'll make a comment on this for the young doctors. And all of you may be confusing, why is it not tombstone? Why isn't it shark fin? If you look at the QRS, it is wide. So the portion that looks elevated is actually part of the QRS. That's the distinction that we need to make. Is it the ST segment that is elevated, or is it the QRS that is looking like? So sometimes it's very tough, but then you have to look at the clinical scenario of the patient also, which is basically a COVID patient who is very sick, acidotic, and look at the electrolytes. If the electrolytes are abnormal, then you have your answer. Taking this patient to the cath lab poses a significant problem, not only for the patient, but for the staff. So yes, we have to take this patient to the cath lab if need be, but we cannot expose so many people to this risk of infection unless we are sure about it.
And this pattern is very important. Shoulder down, ST changes. That is usually not ST elevation MI.
Great. Thanks, Abid.
Yeah. So Rafique bhai, this is completely for you because I don't know what is the right answer.
Oh.
No story.
Okay. So let's see what the audience say.
Yeah, we want a poll. This is a good ECG for our participants.
Good ECG. This is a fantastic ECG.
I called it narrow complex tachycardia.
That's good enough for an interventional person. Like, I will call any ST elevation as VT because it looks wide.
The clue for the youngsters is that sinus P wave has a typical pattern of presentation in inferior leads. You should not deviate away from that. We should remember that. Now look at the ECG.
But my only thing for any doctor is that don't commit to sinus tachycardia. This is not sinus tachycardia.
The dear person, please answer. Dr. Sadi, Muqaddas Hussain Sadi. Sadi bhai, please.
Have you given the poll?
Yes, sir. The poll is ongoing.
Okay, good.
Few seconds left to stop.
Please vote. You cannot be wrong. Everything is welcome. I'm sure the panelists will be also divided here.
And I think Rafique sir will accept all the answer finally.
Okay.
B, AVNRT.
Yes. So who will comment on it?
Acha. Sadi bhai, Dr. Sadi, Muqaddas Hussain Sadi, are you here? MG Azam, Mohammad Shafiq.
Now, Dr. Mohsin is here. Mohsin, why don't you make a comment?
Mohsin can make the comment.
Mohsin Hussain.
This, sir.
Why don't you make a comment?
This is narrow complex tachycardia, and rate is around 150 and
more
than 150. Yeah.
166.
Rate is 166, and it is more likely that is atrial tachycardia, or it could be atypical AVNRT, or it could be that is atrial flutter with twist to an blocker, something like that.
That is among the four. D is not possible, na?
Atrial tachycardia is most likely.
Atrial tachycardia. I would go for that.
Atrial tachycardia most likely. Second, atrial flutter may be possible.
Okay. So can I comment on this?
Yes, sir.
Yes, sir. Now
Okay. So if you look at the bottom strip, the sharp complex before the QRS looks like a P wave. That's not T. And it is of same morphology. So that takes out multifocal atrial tachycardia.
Right, sir.
So that's out. Now rate is 166. I don't see a second P wave in the middle. 166, if it is 1-to-1 flutter, that's too slow a flutter. If it is 2-to-1 flutter, Habib, can you go back, please? And the slide view. You have gone back to, yes, good. So if it is 2-to-1 flutter, that's too fast a flutter. But it is still a possibility, but I think it is not flutter. Now, this tachycardia is what we call long Rp tachycardia. And for the audience, if you measure from the R wave to the P wave, that is longer than P to R. So long Rp tachycardia, two diagnoses, atrial tachycardia or atypical avineural reentrant tachycardia. Now, if it is atypical avineural reentrant tachycardia, I would have expected the P wave to be inverted in 2-3 AVF. Why? Because it is going backward into the atrium. It is not. So based on that, my primary diagnosis is atrial tachycardia with 1-to-1 conduction. But these are all valid considerations that we have to keep it in mind. So even when I'm sure that this is atrial tachycardia, in my mind, I must think of other diagnoses so that I can rule them out. So that's what I think it is.
Sir, atrial rate.
Interestingly,
Sir,
this was in the, go ahead, otherwise.
No, sir, my question to sir. Atrial rate nearly 200. Does it help to differentiate between the atrial tachycardia and atypical AVNRT? Sir, atrial rate is nearly 200.
The rate is 166. So that can be anything. I mean, it's a little bit faster atrial tachycardia. And if you know that the definition of this atrial tachycardia versus flutter is kind of question of semantics, is it a micro reentry atrial flutter or macro reentry? If it is macro reentry atrial flutter, it most likely will be in the category of atrial tachycardia. So, Hafiz, did they have a diagnosis on this?
No. So I called it atrial tachycardia, long RP. So, and then I was thinking that why they did not call us for consult. Interestingly, the patient actually a post-trauma pneumothorax chest tube, and I was curious why they did not call us. The trauma team saying, oh, there's a sinus tachycardia. We gave fluid and chest tube, and then now patient in sinus rhythm. So, but I told them.
No, I think still it is atrial tachycardia because it is so narrow P wave.
Yeah.
And
that's not
I think the fluid basically stress precipitated the atrial tachycardia. The treatment will be if it doesn't come back, we don't have to do anything about it.
Yeah, exactly. But I was grateful to them that they did not call it STEMI because AVR, ST elevation, and ST depression. So don't read any STs on the face of these arrhythmias. Now, this is the one actually, Rafique bhai, I want your help because this patient is still in our hospital and we are debating. So it's a management issue. So mitral valve and aortic valve surgery. And after that, this patient is doing this.
Yes.
So the choices are this AFib slow ventricular rate, junctional rhythm, complete heart block with ventricular escape, and second degree AV block.
Okay, let's see what the audience says.
For the audience, I tell you that when we mapped, this RR interval is regular, except this one here. But the rest of the RR is regular. And this, I just say that, the RR interval is all through regular, except one here. And the PP, Rafique bhai, PP is also regular and little faster than the RR.
So I will put the poll out. Don't show me that again. Like, go back, please. Yeah. Let them answer.
It will be a tough one, actually. because the patient is doing great. Before we send the patient home, do I need a pacemaker? And EF is 35%.
Yeah. So have we got the answers yet, or they're working on it?
They're working on it.
Okay. Oh.
Complete heart block.
Okay. Shall I answer, or anybody else wants to
Yes,
answer?
of course.
Can I say
So
something?
actually,
Can I say something?
Jamil,
yeah, please, Dr. Jamil.
If we look at the bottom strip, it seems like that it's junctional rhythm, but with a retrograde P wave. But on the fourth complex, the P wave falls on the QRS complex, and there is definitely no definite relation with the QRS complex. So it seems to me like there is AV dissociation with junctional escape. With a narrow compressor from the His bundle, the rhythm is coming.
Okay, all right. Anybody else?
Jamil, I have a question to you. Lead one, you see, lead one and V1. The P wave is.
Hafiz, go back, please. Go back, please.
I wanted you to see
No. Please go back. Yeah, we'll have to stay with this one.
Okay.
Jamil.
Because if you want, let me know when you want me to go to this one.
No, go back, please, Hafiz. Yes.
Sir, my question to Dr. Jamil, sir. There is ST distortion in lead one. You see, there is ST distortion in lead one. That is a
lead one. Everywhere there is some ST depression in V1 also. These are due to the P wave of the sinus. P waves are falling on the ST segment. That distorts the ST segment.
That is the P wave is retrograde.
No, there is no definite relation. If you look at the bottom strip, rhythm strip, there is some variation in the gap between the QRS complex and P wave. Somewhere it is on the fourth, it is just up on the QRS complex latter part, and there in the first bit is quite little later. It is shorter and fall on the QRS complex. Then there is no QRS complex and a single P wave. After that, again, it prolongs slowly.
Okay. Can I comment, Hafiz?
Yes, sir.
Okay. So I'm going to start with choice A, FE with slow ventricular response. If you look at the bottom strip, after the fourth QRS, there is a P wave.
Yes, sir.
So FE with slow ventricular response is out of question. Second will be junctional rhythm. Now, if it is a junctional rhythm, you expect that to be regular. That means, but there is a gap here. What it means that this P wave, the P wave where I can see independently, is causing the next QRS complex. And then if you follow that QRS complex, ST segment looks funny, but then it changes a little bit. That means this is the P wave. The P wave was here. Even though Hafiz said that it looks regular, actually it is not. There is a variation. The first RR interval after the conducted P wave is 840 milliseconds. Next one is shorter. So there is subtle PR prolongation. So basically after the pause, first one conducted, second one conducted, third one conducted. Now Hafiz, if you show me the next ECG. Next ECG, please, Hafiz. You can see it better here, that after the third QRS, there is a P wave in the ST segment which did not conduct. Next one conducted, conducted next one, and there is a block. After that, it looks like 2-to-1. So this is actually Wenke bias. I've seen a couple of these patients after specifically mitral valve surgery. So what we did, the question was what to do. They want a pacemaker. I said, no, you don't get a pacemaker. we make these patients walk around in the floor to see what happens to the heart rate. If they continue to have one-to-one conduction, unless they have any significant symptom or persistent 2-to-1 heart block, then we just send them home without beta blocker, or if possible, if we need beta blocker, we'll start them on beta blocker in the hospital and make them active. So this was not complete heart block. The first ECG was Wenckeva heavy block with baseline first degree, and which is more clear on this ECG rhythm strip. You can see Wenckeva followed by 2-to-1.
So we are walking this patient for almost a week now because our EP guys are saying that wait and walk. So I'm walking the patient and not doing anything better. And no MEO during the surgery, got MEO bolus. No, and no beta blocker for almost 6 days, 5 days now. So an EF 35%.
How old is the patient?
Patient is like 59, something like that.
I'll send him home. I will send him home with the heart monitor outside. He may, the problem is we EF 35. If I put a dual chamber pacemaker in now, what happens? The EF is low later on. Unless the patient is having significant symptoms, I'll send him home, bring him back, and follow up with another patient within a week or two to see what happens with the rhythm.
But the other question, Rafique bhai, but there is a potentially survival benefit drug, beta blocker, that we are not able to give. How do you take that into consideration?
Oh, no, that's why I will start it in the hospital. I will start the beta blocker in the hospital, low dose. I can give carvedilol probably. I will not give metoprolol. That's a little bit more. Carvedilol, I will take it up to 6.25 to see what happens. And if of course the problem will be at this point, you cannot put a defibrillator in. You can actually make a point, but he's 58-year-old. If I can avoid a defibrillator in this guy, that will be great. And that will be that. So I'll start the beta blocker, see what happens in the hospital, and then make a clinical decision based on that. I mean, we had a couple of patients, all of them, we have avoided pacemaker. One actually came back and then we put a pacemaker in.
So let me tell you what we are doing, because after a lot of negotiation with the EP guys, we are starting beta blocker, and the EP guys quite rightly saying, I'm not going to put a defibrillator. I may put a pacemaker. And then, so if we're giving beta blocker and then patient cannot tolerate and goes down, and by the way, I could not show you the slowest heart rate, which is 30 reported in the night. And I don't have any documents, so I cannot argue with DP guys. So this guy is here for 7-8 days now. We are walking. But this is
Hafiz, this is the problem. When you say heart rate 30, when the surgeon says heart rate 30, I want proof of it.
Yes,
you
I
need
know.
to show me an ECG of heart rate 30. And every time I ask for ECG of heart rate 30, nobody can find it.
Yes,
and they keep coming back. So somebody have to document the ECG. This is not only problem. Yes. So I'm happy that Guru Raj is following what I think should be done. Tell him that I'm happy with him.
Yes. So we'll let you know what happens next. But that's what we have. Thank you so much.
Thank you.
Sir, we want a comment from Orun Maski regarding the management of the last patient, Orun Maski. The patient has got the heart failure and this kind of the rhythm. Orun Maski, he deals with the heart failure patient, sir. Orun Maski.
So, as Hafiz Bhai already said, we should put patients in beta blockers. So, in those scenarios, if you have to put beta blockers, add small doses of carvedilol and see how it goes. And in those cases, permanent pacemaker may be useful, and newer drugs have come up, like SGLT2. Those are the drugs which have come up. Then we can add RD, diuretics, SGLT2. So these are newer drugs which has come up. So maybe we can put that one. And the issue here is beta blocker, which is very important. In that case, I think permanent pacemaker should be a choice if we have to go for a beta blocker.
Yeah, I think I agree, because Hafiz, what you are going to face with this patient, that this patient has baseline marked first degree AV block. That is the problem part. And between ICD and pacemaker, he may improve his ejection fraction if we do septal pacing, and then put a dual chamber system in, which is less complex than putting a BiV, and then bring the patient and then aggressively beta block and improve the heart muscle function. Then we can get away without a defibrillator. So no question about that part. But clinically nowadays, if somebody has an indication for pacemaker, we waive that 30-day waiting period, a 90-day waiting period. So we can justify by defibrillator implantation in patients with low ejection fraction who needs pacemaker otherwise.
Even if it's non-ischemic?
Yes, because basically the problem is that this patient, if the patient has indication for pacemaker, has cardiomyopathy, you can make that. Before we could not put it in, but now we have an option. I can either choose ICD or pacemaker, whichever I prefer based on my clinical judgment. Before we could not put ICD in.
I'm actually repeating another echo and calling the EF 40%. So that,
good. All right, thank you.
And quietly giving carvedilol 12.5, not 3.25. I'm making it, so because we need bed, we need hospital bed.
Yeah.
Okay, thank you, Rafique.
Thanks.
Okay.
Wadud Chowdhury.
I was actually enjoying.
No.
This is a real life scenario where we are in a dilemma, and then sharing these experiences actually help us in a particular case that we'll be facing in future.
I think one of the for the
with
young
the
doctors.
CCG initiation, sir.
Yeah.
With the CCG initiation of the beta blocker for heart failure and gradually increasing the dose, আমাদের জন্য এটা very difficult হয়ে যাবে যে with the CCG and radical we are putting or we are shifting the patient to indication for permanent testicle implantation rather.
Yeah, the comment was that you are breaking up that if we start beta blocker, we are going to put this patient into a high grade AV block. But we have no choice in a cardiomyopathy patient. If adding beta blocker proves the point, then we have to do it. And it is better if we are being done in the hospital. If we don't do anything, then we are not treating the person. So what I want to mention to the young doctors, look at here, we have a group of senior cardiologists, and we have case that we are discussing. Hafiz is in Nevada, it's in United States. We have cases where we need to customize the treatment. We need to consult each other. That is, in medicine, nothing, there is an algorithm, but every patient is different. And we have to customize their treatment. We need to think about them. And we will differ in our opinion, but at the end, come up with something that is appropriate for this current time. After 10 years, that theory may change. That's why I never look at my old ECG interpretation, because my thinking process have changed. I always look at the ECG and interpret it again. Same with medical judgment. But this is a wonderful session. Thank you all for participating. And I really thank the faculty for staying long. And it increases, I don't know the audience, but it increases my knowledge of cardiology. Thank you.
Thank you, sir.
Wrap up the session, sir, please.
রফিক স্যারকে আমি একটা জিনিস জানতে চাচ্ছি স্যার, আমাকে একটা আনসার দেওয়া যাবে স্যার?
Sure.
একটা ওই যে 48 ইয়ার্স একটা জেন্টলম্যান, মানে ও সিভিয়ার চেস্ট পেইন নিয়ে আসছে, শুধু ইসিজিতে V1 থেকে V6 ST ডিপ্রেশন, আর কোনো চেঞ্জ নেই, হার্ট রেট, রিদম, বাকি সব ঠিক আছে। হাউ শুড উই অ্যাপ্রোচ ইট?
আজিম কি রোগীটা নিয়ে ক্যাথ লেবে নি? আজিম কি ওই রোগীটা নিয়ে ক্যাথ লেবে স্যার?
Azam, this is a question for Hafiz, not for me.
Very true. You take the question to the cath lab and find out.
This is the way I believe. I mean, even though I'm EP, we used to take non-invasive calls. And I believe that when in doubt, I like to know the coronary status. It is much easier. And I always go for definitive test, which is a coronary angiogram. And if you look in Bangladesh, you do CT angiogram, it's a good test. But when your pre-test probability suspicion is high, I would rather look at an angiogram cost-wise. In Bangladesh, probably cath and a CT angiogram is the same cost. And if we do one test, if I have to do one test on this patient and I have confusion, I'll do cardiac catheterization and be done with.
স্যার আমি ট্রোপোনিন পাঠিয়েছি আর হচ্ছে র্যাপিড রিজেন পাঠাইছি যদি হয় আমাকে তখন যেতে হবে
স্যার খালি কিন্তু ঠিক আসল কোশ্চেনই করছে
This is the problem of Azam.
আজম তুমি কি মনে করছিলে তো রফিক ভাই তোমাকে বলবেন না যাইও না
যদি একটা সাপোর্ট পাওয়া যেত আর কি
Thank you. Okay, all right.
So, Professor Wadud Chowdhury, please wrap up the session. And
by the way, Azam janayo ki paila.
Right.
Next week.
Thank you, everyone. This was a wonderful session. We have a beautiful cases from Professor Toufiqur Farouk, which is given rise to a lot of discussion and different viewpoints. Again, we have beautiful presentation from Rafique sir and Hafiz Bhai. It was actually mind-boggling because the discussion actually led to discussion about not only pure cardiac cases. These are real-life cases where the patient present with complex problems. We deal with complex problems in real life, and these are the cases that can help us to gain some insight when we, in our own life, face similar problems. Thank you, everybody.
Thank you.
Thank you.
And Ribhu and your team, Kamrul, please. We are really grateful to you. You have been toiling with us for such a long time, for 1.5 years almost. And we, the faculties, are grateful to you for you have given us a platform to discuss amongst us about the wonderful world of ECG.
It is always a pleasure. Thank you, sir. Thank you so
much. Next Sunday, Professor M.G. Azam, followed by Rafique sir and the Hafiz Bhai. So, Professor M.G. Azam.
আমি 2-3টা কেস দেখাবো
Good, perfect.
Okay, then M.G. Azam followed by the Abdul Al Jamil. Welcome, Jamil.
Yes.
And Professor Arun Maski will waiting for you in the coming session. Professor
Yeah,
Arun.
I can show 2 interesting ECGs too.
Next after the right. I'll let you know. Okay. Thank you very much.
Arun, wonderful. We'll be waiting for you.
So how often? One question was: how often do you get LBV after COVID injection?
LBBB.
Yeah.
I don't know. I have got SVT, atrial flutter.
I have one ECG. I have one ECG. I have one ECG.
Atrial fibrillation, all this. But bundle branch block, no, I haven't got anything like that.
Two interesting ECG. Now, some time, whenever you say me, also.
Yeah.
Excellent. That is the coming Sunday, next Sunday.
Next Sunday is fine.
Okay. Ribu,